today. My name's Clair Sullivan, and I am the Director of the Digital Health Centre at the University of Queensland. Today I'm going to talk to you a little bit about the disruption of research. And before I start, I would like to acknowledge the traditional owners and their custodianship of the lands upon which we meet today, and acknowledge any First Nations people in the audience. The reason that I work so hard in this area is the hope that digital technologies may help us in some ways improve the outcomes for First Nations people. All right, so when we set up the traditional research paradigms, these are the type of patients we were looking after. So people that were relatively healthy and fit with short lifespans, and they often had a single problem. So here, for example, it would have been quite easy to do a randomized control trial on the benefits of traction in fractured legs because all the subjects were young and fit. These people didn't actually have a lot of contact with health services, so they would maybe come back to outpatients 3 months after this event. And then often the next time they came in contact with the health service was when they had a catastrophic medical event at the end of their lives. That's very different to the type of people that we're looking after now, where chronic disease is really prevalent. Most people over 65 have 4 chronic illnesses. So this population has very different needs and also generates a lot more data than our traditional populations. So do we as researchers need to update the way that we think about research? And I think we do. And one of the real drivers for this evolution has been the fact that we collect rich clinical data on every patient, every time in real time. And this is just a step change from when we would write paper notes down. We're also coming to the realization, I think, that randomized controlled trials are great for specific populations, but they're very expensive. And interestingly, once the randomized controlled trial is done, it's handed to clinicians, and it's the clinician's job to apply that randomized controlled trial to their population, which is often very different to the subjects in the RCT. So I think we're due for a bit of an update. And of course, I'm going to talk about digital health research. In digital health, the data is centered around the consumer and not around a disease. The data is collected for every patient, every time in real time, and the data is available in a dynamic form to healthcare providers and researchers and the governance system. So it's really bringing, I guess, healthcare and quality improvement research together. That's not to say that traditional research such as RCTs are not effective. They are, and they're really effective for single issues. So does a particular drug work? And we know that RCTs are the best for doing that. But remember that consumers often now have multiple diseases, and probably that reductionist approach may no longer be fit for purpose. And this quality improvement idea is where research meets practice, and digital platforms enable this. So if we compare a little bit, I guess, the traditional research and digital health research and have a think about the implications. So when we're looking to research a problem in a traditional research setting, we have to define a size of the cohort and the time of the cohort. If we're using routinely collected real-world evidence, we can collect the data on every patient every time. This, I guess, in some ways really changes the idea of a power calculation, and one of my colleagues describes it as the switch to the infinite cohort. We do have to be mindful that not all clinical information systems collect a representative population, and so we do need to be very mindful about who is in our sample before we assume that it is representative. In a traditional trial, the analysis occurs at the end of the study or at agreed interim analysis points. In digital health research, we can write AI algorithms that analyze in real time. And this is an amazing shift in terms of being able to detect either efficacy or adverse safety signals in real time. The problem we've got around this is that our statistics workforce is very much trained on intermittent analyses. So we do have a problem there applying this idea. I don't need to explain to this audience the pre-post randomized controlled trial design. However, we're now exploring adaptive and pragmatic trial designs. That allows us to, for example, monitor outcomes continuously and to stop the trial if certain thresholds are met. That's impossible almost unless you do very frequent interim analyses in an RCT. That does require a shift in thinking and a shift in governance. Data extraction. So in a traditional trial, it's collected by the researchers independently. They consent the patients and they become the data custodians for that cohort of data. In digital health research using real-world evidence, at the moment, the health service remains a data custodian. There is quite a considerable amount of resources and skill needed to extract the data from clinical information systems. And we don't routinely consent every person for research when they enter a healthcare facility in Australia. So there are some issues around making sure that we have our data custodians comfortable with this, and also that we cost in the data extraction into our grants. Consent is very clear in a randomised controlled trial. At the moment, we're using consent waivers and hope to shift to dynamic consent. But as I'm sure this audience knows, dynamic consent really still does require development and proper implementation. So those consent issues are very important to consider when we're approaching this. So I'm hoping I'm kind of shifting our thinking a little bit in terms of shifting from purpose-built data collections in an RCT to using real-world evidence. That also prompts, I think, us to rethink what evidence is. So I was trained in evidence-based practice, where you looked at the best available evidence from high-quality research, and then you tried to apply that to the person in front of you. There's a very clear hierarchy in EBM where you prioritise the use according to the methodological quality. It is very rigorous. It does go through an awful lot of vetting to create a randomised controlled trial, as you all know, and it does create standardised best practices. It does, I guess, suggest that we try to use interventions with the most proven efficacy, and all of that is very good and very essential. But the challenges of evidence-based practice is that it relies on the human brain, and I shouldn't say that's a downside, but sometimes it is. Because to take and translate a randomised controlled trial on a cohort of white males from Massachusetts to a First Nations population in Caboolture is a big feat. And we expect our clinicians to do that. So I do have reservations about this. I think it really is in some ways needing to be evolved. Relying solely on evidence from intermittent randomised controlled trials can raise ethical dilemmas because some of these trials, as you all know, do exclude certain patient groups, particularly those with comorbidities, from their research. So I think there certainly are some challenges around evidence-based practice. So I will now introduce the idea of evidence-generating practice. And this is, I think, our next step, where we still need evidence-based practice to determine efficacy, and we need evidence-based practice to tell us, will this work under ideal conditions? What evidence-generating practice does is say, will this work in the real world? And this is where we really generate evidence through routinely collected healthcare data. It relies on generating evidence in a particular context, continuous improvement, and flexibility. The advantage of evidence-generating practice is that it generates evidence directly from your context. So in the randomised controlled trial I described earlier, we would implement those findings, but then we would monitor the outcomes of those people in real time, and we could change our practice accordingly. And we can change and improve our practice using evidence from our own work. And this allows us to be novel and creative, and it provides deeper insights into the application of those interventions in our context. It can produce data quickly, facilitating faster feedback and rapid learning cycles. But nothing's without its drawbacks. And I think we have to be very careful about evidence-generating practice in that the quality of that evidence can vary based on the rigour of research methods used. There is some resource required to set up this type of data extraction and monitoring. And of course, we always worry about introducing bias in both either the design or the interpretation of results. So certainly many things to keep in mind. So I hope I'm painting a picture for you that real-world evidence, I think, is our next step in healthcare research. We've created a, I think, pyramid to try to understand what type of real-world data is useful for which problem. At the bottom of the pyramid, you'll see synthetic data. So we now have the ability to synthesize very large data sets to allow exploratory analysis without moral and ethical implications. In the interest of time, I don't have a lot of time to talk to that, but it is becoming increasingly popular. We can also map clinical information systems to common data models, and this allows an element of abstraction and de-identification to give our data custodians more confidence that our privacy is maintained. We also have the ability to federate data sets now, and that allows us to, rather than trying to link data, to send the code to individual data sets. Again, in the interest of time, I'll have to skate over that, but it is a very, to me, exciting way to join data sets without physically bringing the data together. And of course, at the very top of the pyramid is routinely collected healthcare data. The reason I've done this pyramid is to show people that there's lots of different ways that we can use real-world evidence rather than simply going to probably the one with the highest risk of disclosure, which is the top of that pyramid. Using real-world evidence rightly does require a very laborious ethics and governance process. And I don't expect you all to read this, but I've put it there. This is the pathway that we follow in our work, and it takes somewhere between 12 to 18 months. I make no apologies for this. I think it is important that these checks and balances are undertaken. But you do need resources to navigate them. So this is an example of how we're undertaking those research requests. We've had to automate a whole lot of processes in order to really be able to manage the large volumes of data. And again, in the interest of time, I won't elaborate, but this is resource intensive and it's also skills intensive. So I thought I would now share with you a case study. So this is a case study on a project with one of my colleagues, Professor Andrew Burton-Jones here at UQ. And the question for this study was, do standardised orders delivered via an electronic medical record improve outcomes? And this is an important question because medicine in some ways is shifting from a sort of boutique, artisanal, opinion-based translation of evidence-based medicine into a democratisation of expertise, where we're now able to send these standard orders to a doctor in Mount Isa to treat very specialised conditions. And we want to know, is that safe? Is that the right thing to do? So we've chosen diabetic ketoacidosis or diabetic coma, and this condition is complicated. People at the moment are flying to tertiary centres to have their condition treated just because of the complexity. We have, if you like, downloaded a specialist's brain into these power plans, they're called, or standard orders, and they're now able to be activated in hospitals all around the state. This gives instant access to a less experienced clinician to the routine orders. What's cool about them, though, is that they're very specific and simply pushing a button creates actually action. So it actually orders the IV fluids, it orders the blood tests. And they're live. Unlike a clinical guideline, which is maybe updated every 2 to 3 years, these can be updated in 15 minutes if new evidence comes in. So that was our research question. We had to go through a lot of work to extract the data. We had to link the data. And then we had to go through, and I just thought I'd put up all of the documents that were required to undertake this study. And it took nearly 2 years. So those are all the documents. We had to work very closely with multiple different data sources for this case study. We had to link the data and then, of course, extract it. And we have a very skilled team that does that data extraction. Once you've extracted the data, it does need to be validated, and there's a whole set of how we actually validate that data. And this just gives you, I guess, a taste of what it looks like. Okay. So what did we find in this case study? So we found that when we used a standard order set in a hospital in Queensland, it was associated with a reduction in length of stay. And this is very important because, as you all know, we have ambulance ramping because we don't have enough inpatient beds. And what we showed was a 1% increase in power plan utilisation was associated with an average reduction of approximately 3 hours in length of stay, which is significant. And probably even more significant is the fact that people died less. So the use of these power plans was associated with a statistically significant reduction of 2.7% in a mortality rate. So I'll start to summarise. Rapid digital transformation of healthcare has two really important considerations for researchers, and they are disruptive. The first is the rise of complexity science and shifting from can this work under ideal conditions in a randomised controlled trial to does this work in real life? I actually think that unless we can answer that question, does this work in real life, that we're not ethically doing our duty. So I think that this is going to be very disruptive, but it's certainly here to stay. The second is this increasing momentum to shift from evidence-based practice to evidence-generating practice. And this allows us to understand how are our treatments going, to iterate and improve them, and to create those rapid learning cycles. I don't think these two concepts are particularly new. And these concepts have been present in other high complexity areas such as banking, aviation and mining, yet it's new for healthcare. And that's why this feels disruptive. And I put this curve up because I see us trying to navigate this idea that we have to embrace complexity, we have to embrace real world evidence and shift away from our researcher-controlled isolated data sets to participating in a broader, larger and more complex conversation. And we will see people navigate this grieving curve. I have done it myself. Fortunately, I cycle quite quickly. I'm in acceptance, but not everybody's the same. So expect to see this type of reaction as we do evolve research in healthcare. I'll stop there, but I hope I've given you a taste of the fact that healthcare research is being disrupted by digital. We now have the opportunity to harness large amounts of real-world evidence and to shift away from isolated single population reductionist science to embracing complexity science. This doesn't come without some very important caveats and issues, but I think it's the only way that we're going to be able to make healthcare sustainable for our future generations. Thank you for your time.